Good morning, everyone. We are just now getting started. Thanks for joining us today. I am going to put up a slide about CME credit so everyone can see this. And just make sure if you do want the credit that you change your Zoom name to your LSU email. That will make it much easier for everyone. Okay, can everybody see this? Here's the, okay. And I think we're good. Oh, and I'm going to stop sharing. Okay, got it. All right, get started. Thank you.
All right, good morning, everyone. Welcome. Thank you for joining us this Friday morning. We have a wonderful webinar planned as part of our COVID-19 webinar series. Today, we are joined by Dr. Mary Maluccio. She is a professor of surgery at LSU and our medical director for our neuroendocrine program out at Ochsner. We are honored to have you, Dr. Maluccio. Thank you for joining us. I understand today you're going to be talking to us about cancer and how cancer is being impacted by COVID-19.
Great, thanks. You want me to share my screen now, or are we doing more CME stuff?
Nope, this is it.
Okay, great, okay. So let's just see. So then I am going to COVID talk, and then I need to slideshow.
Yeah.
Okay, go back to, okay. So thank you very much for having me in a sort of a weird virtual setting. So as I said, I am Mary Maluccio. I'm actually a surgical oncologist by training, but my professional interest is in cancer programmatic development. And how I describe that to people is it's about really bringing together a medical professional family around the needs of a very particular disease or patient population that addresses some of their unique needs. And in some cancers that can be just a handful of people, and in some cancers that can require, up to a dozen different individuals to kind of all be on the same page with respect to cancer care. So when they asked me to do this, and I'm sort of happy that I'm doing this now versus having to try to put some of this stuff in perspective even a month ago or 2 months ago, because I think that we're sort of it's coming around the corner and better understanding things. And so we can advise people a lot more confidently on what it is they should be doing with respect to cancer. So why I chose this topic was that it seems to me like everywhere we go, the second that they find out that you're a cancer provider, you've really got less to say about the actual management of COVID and more to say about how it's actually impacting their cancer care, their worry about cancer, their loved one's cancer, their fears over exposure. And so that's actually not necessarily unique to cancer medical professionals. You can be around your dinner table, your breakfast table, a cocktail party, and people are often just like 1 degree of separation of someone with cancer that is going to potentially have questions. And so even if you're not cancer medical providers, I think these are just the common questions that have come up, and that cancer service lines have kind of come together to have relatively standard, not so much mixed messages about them. So I was just going to go over the frequently asked questions. I have around 20 slides. So if I don't cover some of the questions that people in particular are interested in, we can always do those at the end. So what I found is that that really this pandemic in particular, not that there haven't been other things that have contributed to a lot of fear. Obviously, I'm talking to people that lived through natural disasters. And so, so fear is just something that tends to bubble up when there are times of uncertainty, whether or not that's fear that the stock market's going to crash, that's fear over a loved one dying, or this is, but that it's the fear, and then how that fear is affected by information, misinformation, mixed messages, rules here, rules there, and that it's human nature to then sort of get enveloped by that fear. And I think what we would hope to do is by giving information, it is supposed to lessen the fear, not actually increase the fear. So what I tell people, the analogy that I use, I'm really into analogies, the analogies that I use is it's like when you get a test paper back as a kid and you think you did really crappy on the test, and so you stuff it in your backpack without looking at it in hopes that the grade is going to miraculously get better. But the reality is that the grade is still going to be the same grade. And so the information that people are trying to give you is actually that it's kind of understanding the reality of the situation. And yeah, the news is not always great, and the grade is not always great, but that in better understanding it, we're able to sort of move beyond it and take better control of the situation. So it's really about controlling fear. So I really was focusing on cancer, and not about any particular cancer subtype, but just about cancer in general. And so I wanted to start off this slide by saying that there is data coming out of heavily affected areas of the country that are in particular focused on cancer. So I just quote this from New York City. There was something out of Mount Sinai, Montefiore, areas that are highly academic and strong databases. And really, they don't want people to focus so much on whether or not that the cancer and the treatment of their cancer is going to somehow make them that much more vulnerable, that they should have fear of getting the treatment, fear of delaying the treatment, and that this quote, I think, sums up a lot of what their data was showing, was that it is not about delaying or stopping life-saving cancer therapies, but that all of the strategies that are being used is about minimizing exposures to vulnerable patients. And so it's understanding where you fit in the context of vulnerability and then taking the precautions that are necessary, but that there are few cancer or any cancer programs that went and stopped active cancer treatment for patients with life-limiting cancers. So one of the most common questions that is out there, like when people come up at a cocktail party, whatever, they say, does my cancer diagnosis, does the fact that I have cancer, had cancer, or know someone that had cancer, does that make me more likely to get this? And that's where I think there's a lot of misinformation. So the answer to that is no. The exposure and your risk of getting it is the same as your neighbor's risk of getting it. Now, if as a healthcare worker coming into an institution that cares for people that are infected with the virus, yes, there is an increased risk of my getting exposures, and that is the reason why they have the recommendations that the CDC came out with the precautions for healthcare providers versus people that are sheltering in place versus people that are caring for maybe loved ones that were exposed. So the risk of exposure is the same regardless, but the risk that they're talking about is how the disease would manifest. So if you were exposed and you got it, how would it manifest in you as an individual compared to your neighbor? And what medical conditions, including cancer, would make you more likely than average to have harsher symptoms, worse outcomes, and a longer recovery? So what are the things that are sort of glaringly obvious, not related to cancer? So diabetes. So diabetes is something I think we've come to just say, oh, you've got diabetes, I got diabetes, my neighbor has diabetes, everyone's got diabetes. Well, diabetes is a very well-managed disease in many, many people, but the diabetes as a comorbid, as another medical problem in someone's medical problem list, is a significant factor in your ability to fight off infection. And we know that with respect to your recovery from surgery or your recovery from trauma or even your recovery from the garden variety flu. So the diabetes as a comorbidity has really come out as a strong predictor of a harsher manifestation of this disease. And so to throw out some statistics on that, the UK, the British government published their data is a third of the patients that ended up succumbing to COVID in the UK had diabetes as a comorbid condition. And then right up there with that is cardiovascular disease. So that's sort of another thing. We say, oh, heart disease, cardiovascular disease. I needed a stent. I had a heart attack. Well, those things you can sort of rock along in your life and not have those things really give you significant problems, but that when you pile on an additional insult, and this virus in particular, because it affects the cardiopulmonary system, is it will manifest significantly harsher, like 10 times higher likelihood of having a bad outcome if someone with cardiovascular disease was exposed to or ended up getting this virus. So if you were to look at those two comorbid conditions in the United States of America, those are probably two of the most common medical problems that people have and are being treated for. And heart disease in and of itself is the single largest driver of mortality in the US. So for people that have cardiovascular disease, yeah, this is a big deal. And therefore the precautions that they're talking about really do pertain to you. Limiting exposure is really paramount. The other two things that probably haven't come up as often in other viral illnesses, because they don't tend to be so pulmonary or respiratory system focused, is asthma and COPD. So asthma is often well managed with some sort of medication treatment, but that they have found that this virus on top of asthma can be associated with worse symptomatology and worse outcomes, increased likelihood of needing a vent. And then COPD, which is just the inherent weakness of the lungs. That's probably not a leap of faith to suggest that COPD or patients with COPD would be particularly vulnerable if they were exposed, because they have a weakened pulmonary system anyway. So of the comorbid conditions that have really panned out as being highlighted, it's not to say that other comorbid conditions don't matter. It's just that these were highlighted predominantly because they're quite common in the US, and then in combination with the virus has been particularly harsh. So then another question that always comes up. So there's the whole concept of immune compromised. And so what does it mean to be immune compromised? So those other medical conditions that I just talked about, or people that are on steroids, people with Crohn's disease, autoimmune diseases, lupus, all of those diseases are associated with some degree of immune compromise. So when it comes to cancer, then we do talk about patients and active chemotherapy and its impact on your immune system, and therefore your increased vulnerability while on that treatment. So immune compromised just means that your immune system is considered weaker and therefore less able to ward off infections if exposed. But I capitalized if, because it's if exposed. And so the precautions are predominantly trying to decrease your risk of exposure and therefore eliminating then that increased risk associated with being immune compromised. So we make the same recommendations with respect to precautions in patients on active chemotherapy that significantly suppress the immune system. It's just been highlighted by this pandemic because it's that much more important that we are diligent with those precautions. So there are certain patients that are known to be immune compromised. Patients that are on active treatment with chemotherapy, that's why we follow counts over the course of a chemotherapy cycle. And then the cancers that have panned out as particularly vulnerable with respect to COVID have been the blood cancers. Those are the lymphoproliferative disorders like leukemias, and and the patients that have required bone marrow transplants because they are particularly immune compromised. So therefore, the best strategy to decrease your exposure is everything that you have heard like a million times on the news and otherwise, is really being considerably more conscious of washing your hands, not touching your face, your nose, your mouth, wiping down common touch points, which in your house are sort of like the tables, the counters, the bathrooms, the things like that. But it's also your car, the handles and the steering wheel of the car. But in the hospital, the precautions that we take is that we routinely will wipe down the common touch points like elevator buttons, both inside and out, handrails, bathroom handles, and things like that. So it's really just being a little bit more conscientious about what you have touched and what you can do to ultimately clean whatever germs there are from you after that touch point. So the next question was, I have other medical problems as well as cancer, and does it matter if those issues are controlled with medication? And the answer to that is, unfortunately, that's the bad grade, no. So absolutely uncontrolled diabetics are more vulnerable to diabetic related complications, including infections, compared to better controlled diabetics. But that when it comes to those diseases in conjunction with another insult like this viral illness in particular, is that just being on medications that control the disease to a certain extent does not necessarily give you an additional immunity. I think it's definitely better than not being well controlled with any of those comorbid conditions that I described, but it doesn't give you immunity. And the things that have panned out kind of in the data that's coming out of the cruise ships or the Chinese data or whatever is that cardiovascular disease, obesity, pulmonary disease, kidney disease, and diabetes have been the top things that have caused some problems when combined with COVID. So I am on chemotherapy infusions, and should I delay treatment? And people are afraid. They're fearful of the hospital because the hospitals are caring for patients that are infected. And so that the answer to that in general has been no, but that I want the caveat to that to be that it depends, and that most, if not all, of the cancer decisions have been made on a case-by-case basis with conversations that patients have with their cancer providers. So cancer chemotherapy in particular is given and prescribed based on data that drives that prescription. And so unless there's data to suggest that the outcomes are the same with interrupted use, then for the most part, we were doing our best to try to not interrupt cancer treatment. So, but I also do not want people to be fearful that if they did have a delay of a week here, 2 weeks here, even a month here, there was a time early on in the pandemic when there was a lot of fear out there that we were potentially going to worsen, that we had no testing, no ability to identify the people that were most likely to be infected. And therefore, we made those decisions at a time of uncertainty and in the best interest of patients. Now that we know a lot more about the virus precautions, we have testing, I think that we feel very confident pulling people back in for active treatment, and the precautions surrounding the infusion centers are likely going to stay for months in the future as we sort of, try to get a handle on the ongoing kind of, percolating number of cases. But for the most part, if you are on active chemotherapy, we are not delaying treatment or interrupting that treatment if at all possible. But that I did give a Facebook Live about neuroendocrine patients in particular, where that data that drives outcomes is not dependent on uninterrupted use. And therefore, I did not want those patients to worry that if we interrupted their therapy, it was going to have an influence on their outcome. So the way those decisions were made when it comes to cancer was based on the type of cancer, where they were in the treatment, the value of that cancer treatment with respect to in particular survival, and any data that would suggest that delaying or interrupting that treatment would impact that survival. And then the I'm afraid to come to the hospital is something I would have had a whole lot more trouble walking people off of that ledge a month or even 6 weeks ago. I think now that hospitals have gotten protocols in place and we have extreme precautions in place, I don't think people should be concerned about coming to the hospital. But I think individual cancer providers are going to understand in their unique settings, like their infusion centers or their hospitals, how much potential exposure risk there is, but it is quite low. The data would suggest that hospital acquired, meaning people that were negative that ultimately seroconverted in the hospital, is relatively low. So one of the papers that came out of New York was really when they talked about cancer care, one of the major risk factors was the inability to receive necessary medical services. So there were some cancer organizations that came out and cautioned the medical community in general about sort of diverting attention so closely into COVID-related problems that you ignored or you delayed appropriate treatment because, once again, of fear of uncertainty and the utilization of resources. We were having to shift things in a time of crisis. So delayed surgeries, delayed things like that. I think that those decisions were made with absolutely with the best intention for the patient as possible. And a lot of that was coming from the CDC and the federal government. But I don't want to lie to you that there were cancer organizations that raised concerns that the restrictions were limiting people's ability to get treatment that they actually needed. So elective surgeries for curable cancers. We will not know whether or not that is an assumption, a perception, or a reality until we are able to see people over a much longer period of time. Decisions, I want to assure people, were made on a case-by-case basis, and active treatment should not, and I don't believe in most large cancer programs, was actually delayed. So what precautions are being taken? So the temperature check, and so why do we do all of that? Is fever is one of the most common symptoms associated with it. Although what we're learning now is that you can have a whole lot of people just walking the earth, unknown carriers of it. And so temperature alone is not going to be the deal maker. So the other precautions that are in place are the masks, and I have my next slide on the mask versus no mask. The hand sanitizers, we'll never look at hand sanitizer dispensers the same ever again. So hand sanitizers are now all over the place in common areas, even at grocery stores, at definitely at bars and restaurants, in bathrooms, in hospitals, waiting areas, all, you name it, there's hand sanitizer. If I were to make any advice to people, I would probably say this is the time to keep some wipes in your satchel, or some hand sanitizer, because it's just a really easy way to remind yourself that that you're aware of the touch points. And then the waiting areas, in particular in outpatient cancer clinics, have all been redesigned to take into consideration the appropriate distance. And so my advice to people is to respect those distances. So do masks matter? So there was a lot of misinformation about whether or not masks actually protect you from anything. So, and what kind of mask, and why do certain people have one mask and I have this mask, and then they're cloth masks, and people are making masks, and are those health grade masks or whatever? And so the reason why they kind of shifted gears on when and where you should be wearing a mask actually only recently came out, probably within the last month. And my interpretation of that data was that came out because the degree of asymptomatic carriers of the virus was not recognized until we started testing people. So then once we realized that there were a lot of people walking around that were asymptomatic, but likely shedding the virus, then the recommendations that had previously been made about only wearing a mask if you had been exposed to an individual with COVID, or only wearing a mask if you were particularly vulnerable, or only wearing a mask if you were in certain situations, kind of went out the door. And they were like saying, well, until we better understand the current rate of asymptomatic carriers, it's just better for everyone to wear a mask under certain circumstances. So where I don't believe that the data is strong is whether or not when you are outside walking your dog and you are maintaining social distancing and or you're exercising, that there's any data to suggest that you need to be wearing a mask. Well, if you were to stick that same person in a gymnasium right next to the person and the thing, I don't even care whether or not you hop over one more treadmill, is that the likelihood of the spread of particles would be too high. Well, then that's a little bit different. But that when you are out in common areas, it's not as if the mask is going to be the deal maker or the deal breaker, which is why I believe that certain establishments do make it an optional. But I think that until we better understand the asymptomatic carriers, I think that just to be respectful to other people and to respect the fact that there is a lot of fear out there, is that wearing a mask is just being supportive of the recommendations that are being made. And it does then keep you as a potential asymptomatic carrier from inadvertently spreading the virus to another individual, or it keeps you from inadvertently getting exposed. So it prevents unintentional exposure. It's all about asymptomatic characters, and it's really about face masks, but it's also about washing your hands and touch points. So what happens if I test positive for COVID-19? So now that the rapid COVID-19 test is is readily available, now all of a sudden well, what do we do with a piece of information when people are coming in for treatment and then they test positive for COVID? And there are protocols in place, and there are recommendations for retesting. And if everyone on this webinar is within sort of the New Orleans area, there are protocols in place with LSU, with Ochsner or whatever for retesting. We do retest people prior to starting chemotherapy, because that's different than trying to eliminate or diminish your risk of exposure and keeping you on active treatment and taking additional precautions. No one thinks it's a good idea if someone tests positive, regardless of their symptoms, to start them on a medication that would immune compromise them in the setting of a positive test. So that's why I say symptoms do matter. So when we go over the symptoms that are associated with COVID, and you keep getting the same questions over and over, and maybe I just get the same questions because I come to the hospital every day, is that one, that's also not going to be the deal maker, the deal breaker, but that if you are symptomatic, I think it's important to recognize that. And if you are a cancer patient and you even think you're overreacting and you say, oh my gosh, are these the symptoms of anything else, or could this be COVID? Now that the tests are readily available, I think that it is better to err on the side of caution and be tested. So symptoms matter. Getting your healthcare professional to understand what your symptoms are, but that we are testing everyone, at least within our cancer service line, testing everyone prior to starting them back onto chemotherapy. So I am on chemotherapy and I feel sick. This is just about like from the last slide. Chemotherapy can make you feel awful. And so, and it's not as if chemotherapy gives you the same symptoms each and every time, although sometimes it's some variation of the same symptoms. But that it is super duper important that if you're on active treatment, it doesn't matter whether or not you tested negative. We take it all really seriously now. We have urgent care centers that are on high alert. We have hotlines for cancer clinics. So you need to call your healthcare provider. If it's after hours, you need to call them on their answering service. Urgent care centers have probably not been nearly as important to us as they are now to be the first line of defense in certain neighborhoods. And then if you can't get a hold of someone, or you're feeling like the symptoms are clearly not the same as they were when you previously had chemotherapy, we don't take anything for granted, and we would send you to the emergency department. So I am in the process of diagnosis and staging for cancer. What should I do? So this is rough because just because the pandemic hits doesn't mean that new diagnoses of cancer are not made. And so then you wind up sort of in the limbo zone, not having the same types of resources available to you to readily get into a doctor's office. So my advice and our attitude about this is that this pandemic, this is where the physician champions in cancer, is that this pandemic should unequivocally not keep you from establishing a cancer treatment plan. So 2 months ago or 3 months ago, when we were all like, what the heck's a virtual visit? Now we're like, oh my gosh, am I ever going to do anything other than virtual visits? So there are medical professionals and even cancer subspecialists that have made themselves available to people in the state, people out of town, people out of state who are having new diagnoses or want a second opinion, new diagnoses, so that they can get advice, get some reassurance that at least someone's on their case, and go over with them the likely treatment plan, even if that treatment plan is not going to be delivered by that person or in that facility. And so I'm not exactly sure what the downtown LSU cancer service line did, but I can't imagine it's going to be that much different than the Ochsner cancer service line. But that it pretty much, we all said that all hands on deck is that if people need to establish a cancer treatment a plan, that we were going to be available regardless of whether or not we were ultimately going to be delivering that care. So we could at least allay some of the fear of the new diagnoses and keep the sort of extent of disease or whatever evaluation was necessary, keep that sort of going so that there wasn't going to be any further delay in the initiation of treatment. So if you're going to do that, the virtual platform has also made it so much easier for patients to have access to their medical records. So the one issue that we've had is when people don't have the IT platform in order to have it readily available, we have had people within the office track down records for people. So if you were to look at the key components of your medical record that any cancer provider would need to give you an opinion, it's going to be this list. So pathology reports, what the diagnosis of it that tells us what the tumor is it breast, colon, pancreas, and what those pathology features are, because those are important for how we make decisions. Imaging results, and in particular, we want you to request the imaging on discs. So digital images are commonplace now. We've even set it up so that in some cases we can get access to those images on a cloud format, but that we need to know what imaging was done and where it was done, and then they may have to call you to say that you need to release that information so that we can look at it. Endoscopy reports like colonoscopies, upper endoscopies, endoscopic ultrasounds, that's important in certain types of cancers, blood work, tumor markers, and then I would just jot down for the person. They're going to ask you about medical and surgical history, some of those comorbid conditions that we went over, and then medications that you're on. So I'm a cancer survivor who receives regular testing. And should I get this testing? Well, 3 months ago, or even 2 months ago, we were doing it on a case-by-case basis. A lot of it depended on how far from your cancer diagnosis you were and whether or not we felt that it was reasonable to hold off 30 to 45 days to get some surveillance, imaging, blood work, or things like that. And I think that most of us in the cancer world are going to say that 30 to 45 days in delay, if it was in cancer surveillance, is not going to be have a significant impact on your outcome. So once we then got through that 30 to 45 days and we were kind of lingering on and the recommendations going forward were a little less clear, then we did start saying, well, we're going to have to figure out how we can safely bring people in for surveillance imaging. So once again, case-by-case basis. 2, it all depends on how far out you are from your cancer diagnosis. So the general answer is that yes, you should get this testing, but I didn't want people to get really alarmed when they couldn't get their endoscopy or whatever, because those were the type of procedures that until we understood COVID better and until we could test people, we felt that it was in the best interest to delay that. And I think all of us believe that that was the right thing to do. So another thing that I found on the internet that I also think has not come up in other Q&As is that people with metaports that have been on active treatment where we drill into them that they have to get those flushed regularly. So those flushing protocols are somewhat conservative. And so it's not like it's, to the letter on the 30th day of the month, but that cancer patients have invested in getting those tunnel catheters in place, and maintenance of those catheters is important. So I would have said that I would have had trouble answering this question 2 months ago when we were struggling to bring people in even for some of these routine type stuff. And now I would say we unequivocally would be bringing in to get it flushed, but that if you are not from the Orleans area or you get your care down here, but you live farther outside of the heavily hit areas, we can always arrange for that to be done in an infusion center closer to home. So the answer to that is yes, you need to get it flushed, and that I don't want you to fret over having had it delayed, but that now we would go back to flushing it regularly. So I can't get to my appointment with my provider. What should I do? Well, it's all virtual. So we have done everything in our power to build a virtual platform that is accessible by the vast majority of people. We will never get to everybody because of broadband issues or IT issues. So all we do is we do then it over the phone. It's not great, and it's not the same as seeing a medical provider. It's not the same as understanding someone's body language or their empathy or whatever. But the fact is that we have all become accustomed now to virtual visits. And it's not as if this cropped up yesterday. Virtual visits have been used by family practice and primary care physicians for probably a lot longer. I'm almost embarrassed to say. But for those of us that really are day-to-day cancer providers, that's just hasn't been a part of our practice. And I believe that it is here to stay. So it has allowed us to keep much closer tabs on people on active treatment. I think that it hasn't, I would hope, hasn't really had a detrimental effect on their ability to get care. And then we are actually within our cancer program doing a study to evaluate how patients have felt about getting their care virtually that would help us strengthen the virtual platform so that people don't feel like the care is in any way diminished. But virtual visits, you should not delay a provider appointment. You should call the office, and if they don't have virtual visits you need to get in, then that's when the second opinion people we come up, and we're more than happy to do that for you in the short term. And then the second opinion has come up actually a lot because especially when you are in a really rare cancer or subspecialty program like ours, is our organization, our neuroendocrine organization, pretty much rallied all of us to become national providers. So the telemedicine restrictions were lifted by CMS. We were able to really deliver opinions regardless of where you were in the United States. And therefore, I highly recommended to people that they get a second opinion, not because they don't have adequate care closer to home, but in this time of uncertainty or they haven't yet started on treatment, even having another individual, especially a subspecialist in that cancer diagnosis, to tell you the same thing that something else said. So having a similar opinion come out of two providers' mouths is very reassuring before you're starting treatment. The virtual platform has allowed us to do that seamlessly. And then what's all this talk about antibody testing? I think I'm almost done. What is all this talk about antibody testing, and should I get it? So antibody testing is predominantly about looking at whether or not you were ever exposed, but that I caution people about putting a lot of reliance on that antibody testing because we actually don't understand whether or not that gives you adequate immunity to the virus were you to get reinfected. So it doesn't give you the get out of wearing a mask free card. So it tests for prior exposure. It doesn't actually test for your ability to fight it off. So there are no change in precautions for people. So we are not pushing antibody testing nearly as much as we're pushing the active virus testing. And then, is there anything I can do to improve my general health? And this is going to be what your primary care physician is telling you, like for the last 50 years, is this is a time of great stress, whether or not it's stress because of job loss, stress because of living at home, having all your kids at home, feelings of isolation, and that has been rampant in the news. So trying to figure out how to reduce stress is big. So for some people that may be yoga, for some people it may be meditation, for some people it may be running. And I think that the CDC did come out with some guidelines saying that the shelter in place doesn't mean that you should never get out and take a walk and get some exercise. So exercise is a well-known stress reducer, and it can maybe take away some of those feelings of being cooped up in a single spot. Sleep is that sometimes when we're bored, we may sleep a little bit more, we may sleep a little bit less. Stress will also affect our sleep. Is trying to get 7 hours of sleep is a natural stress reducer. Weight control, weight in general is an additional influence on your ability to manage stress. So now that we're all sitting at home, maybe this is the time where we can all have a heart-to-heart with how we can just overall improve our health by the old adage, we are what we eat. One of the things is just diminishing your salt, and I won't be the last medical person to tell you to stop drinking sugary beverages. So there are resources that I wanted to make sure to end with. There are resources, and I think that many cancer patients don't know of and don't take advantage of all of the cancer resources that are accessible through the American Cancer Society. So www.cancer.org has not only their baseline cancer resources, but they have additional resources for patients that either have questions or concerns or issues that are directly or indirectly related to COVID. The 1-800-for-cancer is the NCI thing. They also have, very similar to what I have described, they have hotlines for people that have a diagnosis of cancer and have questions and fears related to treatment. And so even the NCI or the National Institutes of Health have made themselves available for people. And then for patients that are in particular living in the Jefferson and I think Orleans Parish, forgive me if I got that wrong, is that was hit the hardest, and where we have concerns over there being bubbling unintentional exposures and asymptomatic carriers, is that there are protocols out there and studies being done that allow for testing. So if you want to get tested, then I would go to www.testnola.whatever, because I can't see the end of it, is that you can find a place, and apparently according to that website, if you want to get tested, you can get tested. So resources for cancer patients, all it is primarily to alleviate some of the fear that's related to it, but that most of it is just about, precautions, and until they tell us to stop doing it, just play it safe and, limit your exposure. Okay, I think that's it. Oh, that's my email if anyone has any questions for me.
Thank you so much, Dr. Maluccio. That was great. Thank you. That was very informative. We do have some questions, so I'll ask you all to post your questions in the chat box. It should be the lower right-hand section of your screen. And I will begin reading them. So we have, thank you for joining us today and providing this useful information, Dr. Maluccio. That's nice. You started out the webinar speaking to your passion for programmatic development for cancer care. How has this pandemic reinforced or impacted your vision for collaborative and united cancer care across the region?
Oh my God. Well, I think it was the Lord telling me something. So I think that it was actually always my intention with respect to neuroendocrine to build a much stronger network, in particular within the southern region, which is sort of a medical desert for NET. But that it's not just about NET when you're talking about cancer programmatic development. And so building that network and being available virtually, I think is going to improve our ability to build much stronger collaborations even across state lines. So our program sees almost 60% of the people that come to New Orleans for their care here come from out of state. And then you can imagine that when they couldn't cross state borders, we were like, what the heck are we supposed to do? And so, so my intention was to do it. And then I felt like, crap, I didn't have enough time to do it before this hit. And then it really was a giddy up, we got to do this. So I think that it raised, it highlighted the need for that. And what I have found in particular in the southern region, where I've reached out to providers like within Arkansas, Oklahoma, upstate Louisiana, Mississippi, and Alabama, is they all want the same thing. So I feel like this pandemic is going to teach us that we can deliver really good cancer care, even if we are not actually partners in the same practice, members of the same institution, in the same practice plan, but that you can build multi-specialty, multi-provider programs. I call that multi-institutional, multi-specialty, multi-state cancer care. And if I were to do this again in a year, I'm going to tell you how successful I've been at doing that, but that is my goal.
Okay, we're going to check in with you.
Yes.
We have another question. Thank you for this webinar. I would like to ask about any specific recommendations for patients on immune checkpoint blockade, which seems to be much more widely commonly used than chemo for patients with melanoma and some other malignancies. Have any studies been done looking at COVID-19 in patients on ICPI therapies?
Okay, don't worry about it, Sam. I know what that is.
Okay.
So the answer is to the last question is no. Although I can promise that patient that data will come out. So because immune checkpoint inhibitors are so readily used in a number of cancers now, we talk about them being immune modulators and not necessarily chemotherapy, primarily because the mechanisms of action and how they're trying to influence cancer growth is different. However, the immune compromise, or that still is active treatment, the additional precautions for a cancer patient on that active treatment would be identical to the people on cytotoxic chemotherapy. So you would have to take the additional precautions that are suggested. But really, they aren't really that much more additional other than controlling your exposures. And so, for example, I'm sure the restaurants don't want to hear me say this, but that until we get a better handle on what opening up the bars, restaurants, or whatever it is does to the number of cases that are reported, then I would say the additional precautions that cancer patients unfortunately have to take is when it comes to public spaces and going out and doing some of the things that you probably missed doing. And I think I just waited out a little bit longer.
Good advice. Okay, good to know. And touching on something that you mentioned kind of early on and more general, when you were talking about diabetic patients having sort of a harder time recovering from surgery or from all sorts of things, is there a difference between type 1 diabetics and type 2 diabetics, or is it really in general?
Okay, so it is in general. So the UK study that I quoted did not make a difference. They specifically said type 1 and type 2, although they did not go into how many of those patients that died of COVID were type 1 versus type 2. We've always felt somewhat more concerned about people with type 1 diabetes. I think a lot of it has to do with they tend to have diabetes over a longer period of time, whereas type 2 diabetes is usually an adult onset, so they don't have quite as much, years of having that abnormality. But I would say of the data that's come out, the data on diabetes as a comorbid condition is that and cardiovascular disease are probably the two strongest when it came to influence on your ability to recover and survive COVID.
Mm-hmm. Yeah. Another question. I was actually curious about how are you treating your patients right now? You're just doing televisits and that's working pretty well, or how?
Oh yeah, no. So we are an outpatient clinic, and then obviously we're connected to our hospital. So no, as a tumor board, we discuss every patient, like when they would come up for their treatment, we discussed whether or not they fit into that 30 to 45 days where we felt that they were okay. And then we virtual visited that with them, and then had another virtual visit before we started pulling people in. People on active treatment still came in with all of the precautions. And that was even before we had the widely available testing that we have. Now, we are very fortunate that we have not had, have really anyone that I yet know of that had that combination of our cancer treatment and COVID. So I think that the precautions were put into place early on for our clinic, but we continue to have clinic visits with people. But for the most part, 85% of what we did went virtual, and all of our surveillance went virtual.
Mm-hmm. Wow, that's really impressive that you didn't have any COVID patients.
Yes, so the only thing, so that's what I'm saying is that, so we had probably a couple that were COVID, but they were cancer like part of our large net of patients, but it was the COVID that was the problem. We had a couple of that happen, but no one where we had to change their therapy and say, hey, we're going to have to, hold off this, that, or the other thing. We've had a couple, maybe a handful of people that have been asymptomatic COVID positive, where we have then delayed a treatment appropriately and then retested.
That's so interesting.
Well, it was sort of interesting now that you mention it, because the statistics were such that once I started testing a bunch of these people, that all of a sudden I was going to be having 50%, 40% or something. I was going to be telling all these asymptomatic people that they actually had it. So I'm not sure where those statistics come from. And obviously we're seeing a kind of a particular patient group, but that I haven't seen nearly I don't have any symptoms, but then I'm coming in for my scans now, and then they test positive. That's happened like a handful of times, but not nearly. I mean, I'm up to my 250th COVID, test now. So definitely not the 30-40% that the news was putting out there, as maybe we've got a lot of people that are walking around, they just don't know it.
Oh, so that is interesting, because
Yeah, it made me feel
like
better.
in the news, you are, if you listen to
Yeah.
it, you are thinking, I definitely have it. I just don't show symptoms. Like we all think we have, you know, if you were
Yeah.
listening to what the news was telling you.
Yes, well, and I think a lot of the news tends to focus on areas that were heavy hit. So like New York or things like that, and not necessarily little subspecialty, you know, neuroendocrine cancer programs. And so I suppose if you were to go downtown, maybe UMC would be having a very different experience downtown, because the patients that are flowing through there are, you know, patients all like walks of life, not just cancer patients. And so they're probably maybe seeing proportionally higher, but that I haven't noticed it, and actually made me feel a little bit better. And I actually, now that the testing is widely available, I feel like it's a lot easier to make people feel better.
Mm-hmm. All right. So just so everyone knows, I've posted the URL where you can see all of our past webinars, and you can see the schedule of our upcoming ones. And I think that's all of our questions. We really appreciate your time, Dr. Maluccio. This was really helpful and very interesting.
Great. No, I was more than happy to do it.
Thank you. And y'all, you can see this, and in just about 2 days, we'll have this up on our website for you to view. All right. Thank you so much. Take care,
Great.
everybody.
No worries at all. Have a great day.
Bye.
Thank you.